Hello, I'm Tom Martin from the University of California, San Francisco, Helen Diller Family Comprehensive Cancer Center. And I'm joined today with Blood Cancers Today Editor-in-Chief, Dr. Sagar Lonial of the Winship Cancer Institute in Emory, Dr. Shambavi Richard of the Center of Excellence for Multiple Myeloma in the Icahn School of Medicine at Mount Sinai in New York, and Dr. Peter Voorhees of the Levine Cancer Institute in North Carolina. And this is our first roundtable of discussion on BCMA-targeted CAR T-cell therapy. Dr. Lonial mentioned that in China, they have a dual-targeted CAR with BCMA and CD19. That's actually been, they tried it, was Dr. Wan Du as frontline therapy. And so the question then becomes, what space should we start moving these CAR T-cells? And so we've now seen some recent data on moving these CAR T-cells to earlier patient populations. And so Peter, maybe you can give us a little update on the KarMMa-2 and 3 trials, what results we've seen so far with using CAR T cells, not in the last ditch effort, but in the earlier lines of therapy.
Yeah, so KarMMa-2 is a study looking at idecabtagene vicleucel in a number of different clinical scenarios. And one of the important clinical scenarios that was presented by Saad Usmani at ASH back in December is a group of patients with early relapse. So these are functionally high-risk patients. So this was cohort 2A of the KarMMa-2 trial. And these are patients who had to have progression of their multiple myeloma with 18 months of start of induction therapy, transplant, followed by lenalidomide maintenance therapy. So 39 patients underwent leukapheresis, 37 patients received the ide-cel product. Not surprisingly, these functionally high-risk patients were enriched for high-risk biology. So 12 out of the 22 evaluable patients had high-risk cytogenetics, and 4 of them had more than one high-risk cytogenetic abnormality. Importantly, only 24% of the patients had achieved a CR as their best response to their induction, transplant, maintenance course. And 90% of these patients had progressed within 1 year of transplant, and I'll get back to that in a moment. So in this group of patients, the overall response rate was 84%. The median duration of response was 15.7 months. The median progression-free survival was 11.4 months. Now, at first glance, I looked at this and I was somewhat disappointed. But you have to remember the patient population that you're looking at. So there's really nice data from the MRC11 trial out of the UK that looks at patients with early relapse within 12 months of autologous stem cell transplant, and their median overall survival is only 26 months. And in this particular cohort of patients, the 2-year overall survival is 85%. So I think you have to think about the disease population, the patient population here. And I actually think that these are really, impressive results. And then there's the KarMMa-3 study. So this was a phase 3 study that randomized patients 2-to-1 to either idecabtagene vicleucel or investigator's choice. And investigator's choice, and you can quibble with, what was chosen, but, we're kind of confined by regulatory and approval constraints, but this consisted of darapom-dex, elopom-dex, darabortezomib-dex, ixazomib-len-dex, and then carfilzomib-dex. Now, as far as eligibility criteria, these patients had to have 2 to 4 prior lines of therapy. They had to be dara, IMiD, and proteasome inhibitor exposed, and they had to have had progression on or within 60 days of their last regimen. So as far as baseline disease characteristics, they had received 3 median prior lines of therapy, which is a smaller number of lines of therapy relative to the initial KarMMa experience, but 90% of these patients had IMiD refractory disease, 95% were DARA refractory, yet 2 of the standard of choice regimens had DARA in them, and 75% of patients were proteasome inhibitor refractory. And when you look at triple class refractory, 2/3 of the patients in both arms were triple class refractory. And interestingly, 42 to 46% of patients had high risk cytogenetic disease. So earlier relapse, but a high risk patient population. So I think we have to take that into consideration. And not surprisingly, ide-cel won with regards to overall response rate, 71 versus 42%. When you look at stringent CRs, it was 35% versus 5%. And when you look at progression-free survival, standard of care arms was 4.4 months versus 13.3 months for those that got ide-cel, translating into a hazard ratio of 0.49. So reducing the risk of progression or death by 51%. And again, at first glance, I looked at this and I was a little disappointed that the progression-free survival was not as long as what I might have expected in an earlier relapse patient population. But this is just barely earlier relapse relative to the KarMMa-1 and 2 experiences. So I think that this potentially gives us the ability to use ide-cel in an earlier line of therapy. And we can talk about this later, but insisting that patients have 4 prior lines of therapy before they can access either ide-cel or ciltacabtagene is incredibly challenging. So the ability to get this 1 or 2 lines earlier should be a game changer in my view.
Yeah, that's a really big deal, right? Because once you get past the 4th line of therapy, many patients fall out and say, okay, I'm done. I don't want any more therapy. And so you lose a lot of patients that could benefit from such, very aggressive and effective therapies. So similar data, although it's a little bit behind with ciltacabtagene. So Dr. Richard, do you want to tell us a little bit about the ciltacabtagene data?
So KarMMa-2 is a multi-cohort study now looking similar in parallel with KarMMa's in a way, is earlier lines of therapy and, therefore functionally high risk population, et cetera. So cohort A was designed for patients who had progression of disease up to 1 to 3 lines of therapy as opposed to 2 to 4 with KarMMa. So 1 to 3 lines of therapy and len refractory. Cohort B was for early relapse, so relapse less than 12 months after initial induction, whether that was included just plain induction or transplant in the induction treatment, whether they were transplant ineligible or eligible, respectively. Cohort C was for relapse refractory myeloma who had in addition to failures post PI, IMiD, and anti-CD38, was also post prior BCMA therapy, so very relevant to today's age with all these BCMA therapies going on. Cohort D was suboptimal response, so less than CR after induction and transplant. This cohort actually includes a len maintenance after CAR-T. Cohort E was for high-risk newly diagnosed patients, no transplant intended. So these E and F were for high risk and standard risk newly diagnosed, essentially replacing transplants. And E, because the high risk patients, includes len maintenance again after the CAR-T. So those were the 6 arms in CARTITUDE-2. We have some data from the first 3 arms thus far. So cohort A, this was initially reported by Adam Cohen and ASH in 2021 and Herman Einsel last year at ASCO. In fact, they had 1 patient on this, I think, that was treated as an outpatient, so 20 patients on this study. The results were very similar to CARTITUDE-1. And in fact, interestingly, this is now being taken to study further in CARTITUDE-4, which I'll talk about in a second. But so the median follow-up on this was 17.1 months. And interestingly, more than half had 1 or 2 prior lines of therapy. So 40% for 3 prior lines of therapy. So really moving to earlier lines of relapse. 95% were refractory to the last line of treatment. Predictably, 40% were triple class refractory. 35% had high risk cytogenetics. And overall response rate was very impressive at 95%. Deep responses, VGPR or better was all of them, 95%, CR or better at 90%, and stringent CR for 85% of patients. 80% of these patients were MRD evaluable, and they were all MRD negative. So essentially, 80% of the overall group was MRD negative. The median duration of response, again, not surprisingly, is not reached, but the 15-month progression-free survival was 70% on this arm. Again, the toxicities were as expected. 6 of the 20 patients did have neurotoxic events, but 15% were ICANS, and the others were other neurotoxicities, but no Parkinson's-like syndromes were seen in these neurotoxicities. There were 4 deaths on the study, 2 from progression of disease and 2 from infections. Cohort B was presented by Neil Vanadonk in ASCO last year, and this was now intended for early relapse, as I mentioned, 12 months or less after initial treatment, whether that was transplant or non-transplant induction. So it's functionally high risk. The normal expectation for patients like this would be a median overall survival of less than 2 years. 19 patients were enrolled on this study with a median follow-up of 13.4 months. Now, with the CARTITUDE-2, I should mention that management strategies were implemented to minimize risk of what we had seen with the CARTITUDE-1 in terms of Parkinsonian symptoms and things like that. And so 79% of these patients had a prior transplant. And now the overall response rate on this arm was 100%. 95% was VGPR or better. 90% was CR or better. 93% of these patients were MRD negative. So again, very impressive. Median duration of response not reached, but 12-month overall, 12-month progression-free survival was 90% on this. Again, in this study, there was one grade 3 Parkinsonian kind of symptoms. And as I mentioned, so from the CARTITUDE-1, we had learned that there were certain risk factors to delayed neurotoxicity, including progressive disease at post-bridging or high tumor burden or high grades of CRS, and this patient did have all of these risk factors, so not surprisingly. There was one death due to progression of disease on this arm. Cohort C was for the prior BCMA. So this is by definition just a much higher, more resistant group of patients. 20 patients enrolled. 13 had a prior ADC and 7 had a prior bispecific antibody. So 80% of them were refractory to prior BCMA therapy. 90% were triple class refractory, 55% were penta refractory. There's a median follow-up of 11.3 months. And again, not surprisingly for this group, overall response rate was less, 60%. And the duration of response, median duration of response was 11.5 months, and the median progression-free survival was 9 months. So all of this is not unexpected with this very refractory group of patients. 70% of patients were MRD negative, so also slightly lower. There were 7 deaths on this arm, 3 from progression of disease, 1 from treatment emergent adverse event, and 3 from other AEs that were deemed to be not treatment related as per investigator. Interestingly, there was some information on because this then becomes relevant for future sequencing, is who are the people who responded less well, and was found that patients who had shorter duration of prior BCMA therapy and had other non-BCMA therapy intervening between the past BCMA and this study, or a longer interval from the prior BCMA, these were the patients who tended to do a little better. So responders also had a longer time from BCMA to the apheresis as well. So I think all of this was very interesting and important information that we gleaned from this arm thus far. In terms of CARTITUDE-4, again, this is very similar group of patients as in the cohort A of CARTITUDE-2, but this is a randomized phase 3 study of ciltacabtagene CAR-T versus standard of care. There were just 2 possibilities for this standard of care versus Diller's choice in terms of the KarMMa-3. So this was standard of care with either Dara-Pom-Dex or Pom-Velcade-Dex. For these patients, they were Len refractory patients, 419 patients enrolled on this. All prior PI and IMiD exposed and relapsed after their last treatment line within 6 months. So we don't have formal published results on this, but earlier this year, Janssen did announce that the study had met its primary endpoint of significant, PFS improvement at the first pre-specified interim analysis. So eagerly waiting for formal data presentation.
Yeah, I think everybody's really awaiting those data. And that is going to be certainly an earlier population than what Peter presented with the KarMMa-3 study.